acknowledge the passing of our staff member earlier, Nicolette. I know it's been a very hard time for her family and for our staff here, and also to the young Tamahini who lost her life here last week. And I know many staff in the hospital were involved in trying to save her, and that it was a very, very difficult time. So I'd just like to acknowledge her family and friends, and send our thoughts to her family and friends, and also to our staff, who I know it was a very difficult time for them. And I'd also like to welcome two new people with us today. Andrew Fotz, who joins us, it's his day one as Group Manager Medicine, and also Sonia Smith, day 4, so two brand new people, Group Manager Te Aro Maioha. So what I'm going to do first is just have a very quick round of who we are, and then pass to each of you to introduce yourselves to us. So I'm Kim Ngārimu, Board Chair, to my left.
Tony Robinson, Board Member.
Ngā mihi nui, Sonia and Andrew, Hiki Pihema.
Kia ora, Andrew Robertson.
Andy Cranston.
Sarita.
Tēnā kōrua nera te mihi nui ki a kōrua. Ki te haramai i wanganui e tātou, kia mai ai, kia whakakotahi tāna ai, nera te mihi nui ki a kōrua. Ko Josh Wharahinga tōku ingo, so my name's Josh. I'm the Deputy Chair of the board, and I'm also the Deputy Mayor here. Pleasure to be so long.
Kia kōrua, nau mai hoki mai. Nicola Ehauji in Planning, Funding and Population Health.
Well, both Craig Green, I'm the CFO here at Hauora Tairāwhiti.
Jill, hi.
And if I can just pass up to the screen, if you can introduce yourselves to Andrew and Sonia.
Morena, Robin Lona.
Morena, Sandra Faulkner, Board Member.
I think Jim's waiting for me. Tēnā kōrua, o tira, tēnā kōtau. Ko nā Raihane taku ingoa.
Tēnā kaurua. I'm sorry I'm not there today to be there with you for this hui this morning, but I'm sure the welcome is warm in the room there for you.
Kia ora, and kia ora, Tony Lexman, I'm the Communications Manager.
Kia ora. Well, I'll pass to you two to briefly introduce yourselves to us before we head into our board meeting.
Kia ora koutou, Sonia Smith tēnei, Lord Te Rākai Pāka. Thank you for your welcome today. So my background is in nursing. I'm really proud to be here as a group manager for Te Aro Maioha. I just want to mahi to Nicolette Pomana too, who is a dear friend, a colleague, and also my cousin. And it was Nicolette that rang me and said, you know, I think you should take a serious look at this. And so I did. So I'm really proud to be back at Hauora Tairāwhiti. Last worked here as a registered nurse approximately 20 years ago. Of course, all my children have grown up since then, and my 3 daughters in Moko live here in Gisborne, so they're all very happy that Mum's back here. And thanks again for the welcome. Kia ora.
Kia ora, Sonia.
Kia ora. Andrew Potts, first day. Thank you very much for the warmth of the welcome. Very pleased to be here. It's been quite a while, 5 months, I think, roughly from the interview. It's just been a long way, but it's over now, and I'm very pleased to be at Tairāwhiti DHB and to be part of the team. I'm new to Tairāwhiti. This is the first time I've ever been here, but my family are keen to be joining me later in the year, and we'll be settling here, which is a great thing. Previously, I've been in England for the last 3 years, working in the NHS. Before that, I was here for 10 years, roughly, in Northland mainly, but also in Waitemata. And before that, I was working in the NHS for around 20 years. So I've been in healthcare management a long time, and I'm very pleased to be able to work with the team here at Tairāwhiti to improve health here. And I look forward to meeting you in greater depth in the future and working with colleagues on that important mission. So thank you for the welcome.
Kia ora. Okay, so today I think it's really important today that we get through our meeting on time. There's a number of us who are travelling through to Rotorua this afternoon for the Treaty and Equity training tomorrow, and I really want to make sure everyone's got the choice of completing their driving before dark. So we need to run our meeting as close to time as possible. So first off, apologies. We have apologies from Gavin. No other apologies?
From Mary?
Okay.
Did you miss? I let know about the email that Meredith had sent through on a GDC,
Yeah.
but I don't.
I'll double check whether or not she's contacted me and let you know. At page 4, we've got our schedule of interests. Has anyone got any additional interests to note? Carl, any conflicts in relation to any agenda items today? Carl, then we'll go to item 3.1, which is the minutes of the public meeting held on 29th of June for approval. Does anyone have any comments on those minutes? No. Any matters arising?
Thank you.
Okay, then we will move to the action points from the previous minutes at page 13. So I think this is where we hand to you, Jim. Sorry, page 12.
Yeah, the hearing.
He needs to unmute.
And you're on mute, Jim.
How's that?
That's better, thank you.
Yeah, just I need to make sure I have the video up on screen when I press my space bar. Okay, so the first one there, we are still working on that one, proving a little bit more complicated than we thought, but we'll get there. The Code of Conduct decided that easiest thing to do is to actually just take the PSC's guidelines and just turn those into ours. Then we've got it right. So we'll just do that for you for next month. Then you can improve them. And Nicola, you're there. I'm not sure if there's anything further you can update on that one.
Not at this point. We'll just need to move that deadline date out if we can.
Okay. Does anyone have any questions on the action items? We've got no correspondence in the public session today. And then we go to the performance dashboard at page 13 of the board pack. Does anyone have any questions or comments on the performance dashboard?
If I might.
Hi.
Kia ora. Just as a notice from the Te Wairua Nukutai Memeha Hui, there's a general comment around the number of reads, the percentages that were in the reads, particularly around the patient safety and quality. We thought those were rather dramatic drops. Just to note, we were just noting those for consumption, really.
Yeah, definitely issues in there around immunisations, as we've talked about, and there's a bit of an update in my report, I think, or around that, around what might be happening around those. And I guess the other area in there would be around better help for smokers quit, and also that is an issue that we do have, particularly with primary care, around the model now and in primary care, and how we make sure that that advice is getting through to people with that.
I suppose if there was one thing, Jim, it was the as a shining light was the reduction in referrals for obese children. I think we're taking that as a good signal.
Sorry, trying to do it all on one screen is not so easy. Yes, I think you'll find that the numbers there are very, very small numbers. So that's another one where we just one difference in a month makes a big difference.
Kapai, thank you. Thanks, Kim.
Any other comments or questions on the performance dashboard?
Yeah, I did want to ask, thank you, Madam Chair, I did want to ask about our ash rates, and because I expected to see like there'd be a difference kind of between 12 months to this March and the 12 months, the last March, and seen as COVID kind of was in there in regards to our ash rates, but there's no real difference. So I started thinking about the target. Like, do we set that target, or is that target set centrally? So then for me, it kind of begged the question of how I'm sorry, and I'm talking about 45 to 64. I do note that the 0 to 4 year olds ash rates is under the target, which is great. For me, it begs the question: what are we doing in regards to reducing those ash rates? Because I did expect it to be kind of lower considering COVID, but they're the same.
Yeah, so a couple of things about that. What I would say is that Nicola will have more detail about where that target comes from. I think it's probably more helpful to be looking at the rates, at comparison of the rate. In some respects, ash is not so good for the 45 for that age group, because we are actually encouraging people to come to hospital with some of the conditions that are covered within that area, particularly around people with TIAs and stroke symptoms, for instance, to be investigated, and often we are admitting those people to be able to do that. But definitely, you know, we should be able to reduce that, and that's definitely an area that we're working on with a number of initiatives.
Yeah, thank you, Jim.
Yeah, actually, our 0 to 4s aren't under target. So I think that total population really means rest of the population. Is that right?
Yeah. The 0 to 4s are under target.
So we've got 4,211 Māori, but then we say 3,600 total population. So I'm presuming that means rest of the population.
Yeah, is the total population. But the target is 5,730.
I think Kim's thinking if you add the two together, it's above.
I know. It's the rate for Māori and then the total population rate. So the rate for non-Māori is clearly lower.
Right.
Which means the total population, when you look at the total population, it's lower.
Yeah. Sorry, I was misreading that. I see. Very good. That's good. Thank you. Any other questions? No. Okay. So my report, very brief one this month. It's been a quiet month for chairs. We didn't have a Te Whanauataki meeting this month, and we didn't have a national chairs meeting this month. But national chairs did have a brief meeting with Prime Minister and Ministers Little and Hipkins, and the main area of discussion there was the vaccination program. And do just want to relay that the Prime Minister and both ministers were, really strongly expressed their thanks to all of the vaccination teams, particularly for the efforts that are being made, but also to the wider health care staff, because it's not just the teams, it's the whole system that is enabling the vaccination program to roll out. They acknowledged that it was a significant task, and that with a task of this size, that there are, of course, teething problems with it. But they have very much expressed their thanks and their continued commitment to the rollout as quickly as possible. And in saying that, they also had a very strong emphasis on ensuring equity in the program, and particularly as we ramp up and go into Group 4. So that was the main area of discussion with those ministers. Josh attended the meeting with Minister Little week before last, I think it was. Josh, is there anything you wanted to feedback from that?
I'll just bring up my notes. I did send my 2 seconds.
I will have them here actually.
Yeah, well, one of the big points of discussion was around RSV as well, and that's kind of happening nationally. And the only reason why I bring this up is because the DHBs are really feeling it on their own planned care and on their own systems. We're not. Well, last conversation I had, we're not quite there yet, but it's good to kind of give us the heads up that could be a possibility in regards to what every other DHB is going through. Again, the minister did express their gratitude and their thanks for the rollout of the vaccination program in Tomato 2, and like we'd already have seen in the paper and in our emails, the rolling out of stage 3 and stage 4. And to keep that going on, our supply issues have been sorted with being able to get more of the Pfizer vaccine. That was the main things that were kind of spoken about in there.
So the meeting with the Minister, we have been meeting weekly with the Minister of Health, just a brief 30-minute meeting every week, but in discussion between particularly the Minister, the Chair of Chairs and the Director General, that meeting has now been moved to a more in-depth meeting and on a fortnightly basis. And it's just, from my experience with ministers, it's a really big commitment to have, put that level of time on such an ongoing basis into touching base with chairs of their Crown entities. So I think that's an important thing for us to acknowledge, that access that we get to the Minister and also to the Prime Minister. And also just noting that today, the last month we talked about, we'd had our treaty training bump, so that is rescheduled to tomorrow. It's training that the Ministry of Health is offering. So a number of us are travelling over to attend that, and also a number from Te Wairoro and Nukutai Memiha. So that's all I've got. If anyone's got any questions or comments. Cool. Then I'll pass to you, Ngā, for an update from you on Te Wairoro and Nukutai Memiha. And you're on mute, or volume issues.
So there's a couple, thank you, Madam Chair. There's a couple of bits I'll speak to the papers when they arrive further in the agenda. But I really wanted to let the board know we met by Zoom with Mara Andrews and Bernard Tapar from the Transition Unit, particularly on the MHA stuff and how that's all evolving. So it's pretty clear now that the expectations that are going to be on the MRB generally throughout the country, but particularly for us, Te Wairoro and Nukutai Memiha, are going to exceed what we currently do now by huge percentages. The way that it's looking now is that the Te Wairoro and Nukutai Memiha will be responsible vertically, so going up the chain through MHA, but also working laterally across the locality segment. That's going to take a special set of skills that we're really going to have to be searching for. So one of the things we've done is on the 26th of August, Ngā Tuka Hauora, our Māori GMs are meeting. We've asked them to start thinking about what our Te Wairoro Memiha, but MRBs generally, what they're going to be looking like and how they're going to be able to manage. Because if you think about it, the board that we're sitting at today won't exist. So that Wairoro and Nukutai Memiha are going to take over a number of roles that would normally be associated with this board. And so, as you can see, then our initial idea of just reviewing our terms of reference has now exploded into the full-on searching for super Māori, of people who are going to be able to take on all of these tasks going forward. All I can tell you is we've got there is that PowerPoint presentation. When it comes through, I'm happy to send it on, Madam Chair, let everyone get an idea. There are some pretty strong expectations that have been placed. And the key to this is a lot of those will be legislated. So we've got to be really on top of our game about who we get to represent our whole rohe in this makeup going forward. One of the issues is, of course, is that the regions haven't been signed up yet, so we're not exactly what it look like. And so we, Meredith, yourself on Zoom, you're coughing me out.
Where's coughing?
So I just wanted to let the board know our earlier expectations around setting our new TOR have now taken on a new dimension, and we've got to be a little bit more professional and mercurial about how we approach this going forward. There's a lot more involved in this system now that we initially thought about. So hopefully we'll be able to come back in the shortest period of time. But Madam Chair, as soon as we get that PowerPoint, we'll flick it up, and hopefully the board will get an idea now of the extent that these reforms will take in the MHA space. We haven't dived into HNZ space yet.
Hilda, any questions of her? No. Okay, we'll pass to you then, Jim, for your report at page 15 of the pack.
Thanks, Kim. So I just take questions, but I just thought I'd highlight one or two points within there just at the start of it, and you'll see there's a little piece from me around the financial year that we've just completed, and some of the thoughts about that. It's heavily dominated by COVID-19, of course, and the aftermath of that, and the fact that we're still heavily involved with that, particularly with the increasing issues around what's happening in Australia and what effect that might have for us this side of the Tasman, and the vaccination program, which we'll come to later on. There, I would stress too that just because we've got COVID, that hasn't stopped us from progressing a number of other things as well, and not just within that sort of clinical rebound that we've seen after COVID, but in the work that we've been doing around our buildings, the reviews that we've done, and there's coverage of that later in the agenda as well. So it's been a relatively busy year, and then on top of that, we've got the reform of the health sector that we're Nars just talked about, an important part of that, and more to come as we move through, and some feedback to later on around financial systems in the new era. Financially, last month was just carried through to the end of the year. It looks like that will be slightly better than what we were projecting, so that is good, but it'll take us a month or two before we've got all of our period 13 adjustments in there, and Craig's got an update of that in the financial report. Our throughputs, the graphs still are looking flattish in terms of growth over the last few years or months, but certainly at present there are plenty of people in the system, in the health system, requiring care, both in primary care and in our own facilities as well. And Carl is sitting there today as duty manager, knowing that he's going to be leading this a little bit later on this morning to have a bit of a catch up with the team around how we're managing the current numbers of people requiring health services across the hospital and community. The planned care is continuing to show some good progress. I put some stats in there. I think roughly, if I remember correctly, we've had a 60% reduction in off our peak in just over the last 12 months, in the last year, in terms of working on that to get people back into target area around planned care, both for their first specialist assessments and for their treatment. There is, of course, we've put the greatest emphasis around, there's been a 60% reduction in people waiting for an FSA longer than 4 months. And we have a lot more people within the system that have been referred in, and so done a good job to get those people through and into needing those that need treatment, and then got the treatment time waiting down to by 60% as well. There's more work to do on that, and that's the focus of the next 12 months and that trajectory work that the ministry is expecting us to be doing. I put a piece in there around Tairāwhiti review. So Tairāwhiti, our long-term conditions services grouped together within that one building area there. We have put those together in a semi-planned basis and way over a number of years now, adding in more things all along, and time has come to take a look at that. We've had an independent person come and help us with that. Lots of good information that has been put together in a report which we released out to staff last week, and plenty of work to carry forward for that now. So Andrew, that you met this morning, will be very important part of working on that alongside our clinical director at the moment there, Sarah McKenzie. I also put a section in there around the NZNO proposed settlement that is out there with their members at present for hopefully for ratification. A lot of really good things, I believe, in that, and we can talk about that a little bit later on as well. And there are a number of other negotiations that we've got going with other members of our staff at present. For instance, our midwives represented through their union Meris, and the PSA for our public health nurses, for instance, that will be affected by that proposed settlement, and we'll have an opportunity to have that presented to them and consider it as well. And the last thing that I would just want to highlight within that report is around the Well Child Tamariki Order review that the ministry has completed. That has been a review that's been on the cards for some period of time, has taken a very long period of time to finalise because of things like COVID getting in the way of that. And it, I believe, and you might have a comment on that, Nicola, confirms a lot of what our experience in Tairāwhiti has been and the work that we've done with our Well Child Tamariki Order providers, and most especially our iwi providers, who are steadily increasing the share of the work out there in the community, of the value of that work, and the direction that we really need to follow in that way. So we've been at the vanguard of that, and so it's good to see that that's been confirmed within that review. Any other comment on that, Nicola?
No, I think you covered it well, Jim.
Okay.
Thank you, Jim.
Take any questions?
I've just to start with, I just really wanted to underscore a couple of things. One is the really sustained effort and improvements in future assessment and plan care. I think that's a real credit to again, the whole of team who worked really hard to bring those back in an improvement trajectory. And we know that there was severe disruptions early in the year with COVID, and when our plan care shut down, but then also the disruptions with Waikato. So I think it's an important thing to acknowledge the efforts that everyone's made there. And also ditto with the continued 100% reaching 100% of target in faster cancer treatment. I think that's also a really important thing to acknowledge. I know Anil has been working on ophthalmology, how we work to bring that on a similar trajectory. So those were the main things, but also I'm not sure if the board is widely aware, Jim, but wanted to acknowledge your role in industrial negotiations and the nursing negotiations, and undertaking that on behalf of the sector as a whole. So ngā mihi kia koe. I know that takes a lot of not just time, but a lot of savvy and thought and diplomacy and care. So thank you for your work you do on that. Now, does anyone have any questions? Tony?
So in relation to the FSAs, take off what you said about the improvements, but I did notice it's plateaued last month, so I just want to urge that it continues on that downward trajectory. And my other question relates to the page 32, the measles, mumps and rubella catch up for 15 to 30-year-olds. So no immunisations in June. How was this program delivered to our community? Because I know a young person who's not immunised, but how will they access that? How's that educated to our?
So there are a number of different tranches that should be occurring. General practice is an outreach activity in terms of recalling. So anyone who hasn't received a MMR should have been followed up by their general practice in terms of awareness and encouragement to come in and get a vaccination. We also have our 4 Māori providers who will be picking up different parts of the program. Specifically, Ngāti Hauora and Tairāwhiti Health have the vaccination end of it. And then we have our other 2 providers who are in our promotion. They've recently been organised into doing that. COVID's been a little bit of a priority and flu in between. We were always aware that we weren't going to get to it as early as had been hoped at the end of last year. But that's the general way that people should be accessing. Now, that young person can pick up the phone and make an appointment with the general practice to receive an MMR.
But we should have an expectation that GP services are sending out a follow-up for kids that aren't MMR.
They should be following up young people. They're not, originally, I understand they weren't required to undertake this, but we've invested in that in this second series. It's for a specific group of people, a group of people between certain years that wouldn't have automatically received one at school.
Thanks, Nick.
Will we have an opportunity to discuss what our immunisation plan is?
As per Jim's update, we were required to get a draft plan in by Tuesday of last week. We met that target. We're waiting for feedback from the Ministry of Health to say, is this a go or no? Some things we've put in there that might be quite challenging.
So will that come back to the board?
It needs to come back to us first with any of their suggested improvements or exclusions. And once that's done, I think we should be preparing a paper for the board to say this is what we've been asked to.
Same question applies to the Tamariki Ora review report, is there?
There are some, so we've had some early adjustments to our program. So actually from the time I've been employed, we've been pressuring the Ministry of Health to say there's been a movement from one provider to another set of providers. Could they please recognise that? They finally agreed to do that at the end of last year, where our Tamariki Ora providers were boosted to their base numbers. On top of that, we brought papers through around the Tamariki Ora pilot, which both our 2 Tamariki Ora providers are part of. And then there's another piece of work that happens in the national environment that says, now what? And I understand that's underway as well.
Thank you. Josh.
Thank you, Madam Chair. I did just want to mention the FSA stuff. You did touch on the ophthalmology thing, so I am keen on hearing what the ophthalmology reduction plan in regards to FSAs is going to be. But I did just want to acknowledge too, and I want to specifically point it out is in regards to the ENT wait numbers having massively dropped. I went back to our board agenda of April, and there were like close to 500 people on the waiting list then, and now and of those 500, it was something like 300 were in breach of 3 months, 4 months, 5 months, 6 months. So that's all been cleared. And that actually kind of is the segue into my question around ophthalmology. Are we looking at utilising the same strategy that we did to reduce the ENT FSAs in regards to ophthalmology? Is that something that we're having a discussion about at the moment? And so, and wider than that, keen to hear on what the ophthalmology aims.
That's the intent. I might just pass it on to the next phase of the meeting, the confidential part. That's right.
Yeah. Okay. Ophthalmology. No, I think that's it. I think it's for me.
Anyone in the virtually got any questions or comments? Carl? And again, I think this is for public. I wondered if we should have just a quick brief on readiness in the event of an RSV spike here.
So at the moment, we've got our plans in place should we need to create additional capacity for paediatric admissions in particular. If you may not be remember, but in the reconfiguration and the fact that we changed again our ward configuration within the hospital, we left some capacity available on the top floor, ward area on the top floor, so that we would have over the coming months some additional space if we needed it in relationship to general pressure on the hospital numbers of admissions, but also as we were doing the oxygen and environmental work over the coming months to be able to close off ward areas while we were doing that and have somewhere else where people could be accommodated. There's also an option for paediatrics. At present, while we've definitely got more children within the paediatric ward, we haven't needed to move to that. So we definitely have got those contingency plans in place. More of an issue around being able to have enough staff to do that more than actual physical space.
Thank you. Thank you, Jim.
There's just also to note that primary care is actively in touch with our medical officer of health as well.
Great. Thank you. Okay, then we'll note and accept your report, Jim, and move to the financial report. Just before we do that, I think now this is our financial report to the end of June. It's no surprises to any of us. We've had we've had our deficit flagged to us for quite some time. To my mind, the most useful discussion, rather than going through the details of the report, because there are still a number of adjustments to be had, is to think about actually what can we learn from the year that we're just out of to help us in our financial sustainability going forward. And so to me, the kind of immediate things that have jumped to mind are things like, we've seen the escalation in construction and building supply costs and how that sort of, really affected our capital planning. We've seen the real challenges that we've had in recruitment. The borders closed, and that's really affecting how much we're spending on outsourced personnel. By the way, sorry, in the minutes there was something that said cost of locals, and it should have said cost of locums. I'll find that for you. But to my mind, I thought, unless anyone's got any particular issues they want to talk about in the financials, to my mind, I think that the more useful thing is how do we think about our position we're at, or almost at the end of June, for how we run the business for the next 12 months. Over to you, Craig. Or Jim. And it might be that you might want to think about that and bring that back as a discussion paper for next month, rather than kind of plucking things out of the air right now. But those were the nature of things that were in my mind about what would be useful to have a discussion as a board about.
Okay.
Okay.
Just on that page, on that comment, Kim, on page 42, there's a board reconciliation which takes the year-to-date position at period 12, so at June, and we've got an update to the 20th of July with the various movements. So that's position at the end of June is improved by 1.6.
Great. Okay. So unless anyone's got any particular things you want to talk about the paper as it is, that's my preference, is to have a higher level discussion next month about what it means going forward. Ka we'll take that as noted, and also no doubt next month we'll also have the update on our pretty much final position for 30 June or close to.
Yeah, we'll have another
update.
Another 3 watch-ups. Yeah.
Right. Okay, thank you. So we'll then move to 6.6, committee reports at page 44. So if I can pass first to, if I pass to Josh and Heather, if there are any things that you'd like to discuss from your committees last week.
I just want to give context to the Hauora Rangi, and that says recommendation. The committee did not adopt or support the vape position statement or the recommendation submitted. The paper is coming back to us, and it was like the right things were in there. It's just collating and corralling the right things in order to be able to provide the right statement in the right position. So that kōrero will come back to us in a few future Hauora Rangi committee, just to let us know.
Okay. Kapai, thank you. And so we then go to 7.1, the vaccination update at page 45.
So I'll take the paper as read, and just to note that we're moving into, or have moved into second stage of our process with Tūranga Health, who are now gone out into Western Rural and are going community by community. We're in the process of finalising setup of our 2 city sites that will be running for ongoing all the way through the end of 3 into 4. We're still recruiting actively. And I think any questions?
I think it'd be useful if you could just talk a little bit about the national booking system and what that means for people who are sitting at home wondering when they get their vaccination.
Okay, so there are a couple of things that sit with that. Invitations have gone out to our community via our enrolled population through general practice, through PHO. The national booking system, as you will have seen on TV, is now gone live. What that means is that people who are uncertain about whether they're in 3 or 4 they're being directed to go to the website so they can figure out which area it is. Even if they don't though, they can contact the number that's advertised, and what will happen is that they'll either be supported to understand how they can make a booking that suits them from on the phone, or that person on that phone will make a booking for them, and that's linked up to our current Kōwhai site now. It enables people to make a booking that suits them at their time, which is aligned to the hours that we're open.
Great. Thank you.
Just had a couple of questions. Is Elgin going to be a city site? Because in the paper it says May. May.
We are negotiating for, we have negotiated, for a site at Tuananga or Aotearoa, but there are a few site venues that we went to look at. We had one that we could do, but working with the strength of our providers and the way in which our providers work mean that there's manaki, and that means food. We couldn't be in one place there. We had to be in another place there. We've agreed to be in another place there that enables people to be able to sit and have food at the same time.
In the absence of Elgin, where would that community?
It's in Wānanga or Aotearoa in Elgin.
Oh, right.
Sorry, it's the Elgin site there.
Right.
Yeah.
Okay. And then on page, it's the last paragraph, page 46, it's about community resurgence. Can you explain the focus of that paragraph?
Page 46, last
dot point on page 40.
So we've been asked to think about what it might mean if we have a community case of COVID, and what will we do with vaccination? So resurgence is in response to ensuring that we can respond to testing, contact tracing, and enabling our community to receive those things adequately while we continue a vaccination program. And so our teams have been working on how that actually happens. There are a different set of teams. Currently our testing has been outsourced, and that's working very well, while we've built our vaccination team. So what we need to do is enable a pathway of response to occur quite quickly.
So I just wanted to pay credit to the team is busy, all of these different levels and things that are happening. You know, there's a lot of activity going on behind the scenes, and I just wanted to pay credit to that.
Thank you. I think the team will appreciate that.
I'd still quite like to know the staff vaccination rate though for COVID, if possible.
So there are still areas of privacy that are managed within the vaccination program. So the way in which this organisation does that is up to the way in which this organisation does that. It's not.
Can I suggest, given the privacy issues at stake, we might have this particular discussion in public excluded? Any other questions?
Yeah, I got 2 questions. I got asked yesterday by a member of the public who was told that they had to get vaccinated again next year. It was to be an annual thing.
They're booster shots. So this is the first rollout for the country to become to be able to have a kind of degree of herd vaccination or herd immunity. Like every program, such as flu, for example, every year there are new variants that occur, and we encourage people to receive vaccinations for those variants. It is very consistent with how we think about immunisations.
There hasn't been any decisions taken yet about needing boosters yet. It's just some work that the vaccine providers that have developed the vaccine so far are working on as to whether there will need to be. So there's been no declaration that people need to have a booster yet. But it's certainly something that's been talked about with the development of the variants of the virus that may be required in out years.
Cool, thanks, Jim. And the other point was around border workers. So there's an order making it compulsory. Where do we stand with our local border workers? What's our percentage of vaccination rate looking there?
Don't know the actual percentage, but there was about, the estimate there's about 50 people that still needed to be, and that needs to be done by September, I think is the correct date. Is that right, Nicola?
Yeah.
Thank you.
So yeah, that would be helpful to have in committee as well.
Pardon?
Be helpful to have a further discussion in committee.
Okay. Any other questions? Okay, so that brings our public session to a close, unless anyone had any public general business items. No, very good. Okay, so I'll move that we now exclude the public for the reasons outlined in the published agenda. Thank you very much for joining us today. It's always a pleasure to have you with us today, and we look forward to seeing you or you seeing us at our board meeting next month. We're just grabbing coffee, 5 minutes.
Yeah.